Hello and welcome to those of you who have already logged in. This is Josh Rubel. We're going to let folks who have accepted the invitation to this session file in. We'll be kicking off here in about 2 minutes. Thank you again. 2 minutes, 1:02 Eastern US. Welcome, Dr. Shora. We'll be kicking off here in about 1 minute. We're letting everyone file in. Okay, I think we're ready to begin. Good morning, good evening, good night to some of you in different time zones around planet Earth. Thank you to all the assembled attendees and presenters. It is a pleasure to kick off session number 2 of a learning event that we put together a few weeks back. So I'm delighted again to welcome you to the basic course of AI in radiology, session number 2. As I shared earlier, my name is Josh Rubel. I'm the Chief Commercial Officer here at Pexera Health, and I'm connecting to this call from Atlanta, Georgia on a beautiful fall day. It's about 60 degrees Fahrenheit outside. It really couldn't be nicer. Of note, this is our second session in a two-part series. We've got a recording from yesterday. If you'd like to access, we can make available to you as a follow-up. I'd like to thank our presenters first and foremost for putting together a valuable set of content. And we know that this is a large-scale time investment for those of you attending. Thank you for carving this time out to better understand and learn about what's happening in the world of AI with a particular focus in radiology. Today, you can see the agenda on the screen in front of you. We'll be starting with a physician perspective, and I'm excited. We'll have Dr. Safwan Halabi from Northwestern with us today. We'll follow that with additional drill down into the CNN that Razvan shared with us yesterday. The initial discussion will be diving a little deeper. And then finally, we'll close the session with a discussion around advanced learning paradigms and really some of the usability sort of questions that are out there related to ethics, bias, and integration into workflow by our fearless leader, Dr. Mohammed Shora. Right before I hand the ball over to Dr. Halabi, I just want to make sure the team is aware we will be answering questions on the fly using the Q&A function in the Zoom user interface. So please locate it. It's on the bar at the bottom of your screen, and you should be able to ask questions. I'll be triaging and hopefully answering some of those in the chat. If we don't get to them in the discussion today, we'll make sure to follow up similar to how we responded yesterday. So with that, I'm very excited to hand the ball over to Dr. Halabi. Again, welcome, and we're excited to hear about the physician perspective.
Great. Hello, everyone. I'm Safwan Halabi. I will be presenting the talk on the physician experience. Hopefully, you can all see my slides, and I will get started. I wanted to thank Josh, Razvan, Mohammed Shura, all of the Pexera team for this invitation. I've been very happy to collaborate with them over the past several years and have been really excited to see this addition of AI into their systems and promoting this educational piece. So this is my talk. I am a professor, associate professor of radiology at Northwestern University School of Medicine, and I'm a vice chair of imaging informatics at Ann and Robert H. Lurie Children's Hospital of Chicago, and I'm coming to you from the suburbs of Chicago today. These are my disclosures. My objectives today are to really take a deep dive into the requirements, challenges, and pitfalls of implementing AI algorithms into clinical practice and really describe the current and future role of AI as it plays out in the radiology practice. And I think many of you, wherever you are, as either as clinicians or as developers or as technologists, it's going to be very important to understand how this will fit into your repertoire and also from the whole pipeline. And, I think the team has done an awesome job in discussing this pipeline. Like it all starts with that clinical problem, right? You have the data collection, the model training, the validation, deployment, and monitoring. I really wanted to focus on the clinical problems which face clinicians and physicians and patients. I'm going to touch briefly on the validation piece and talk a decent amount about the deployment and challenges around the deployment and monitoring. So I just wanted to emphasize how important these validation pipelines are. I'm not going to go into the whole, developing an algorithm. This is not that talk, but I really want to talk about how critical the external test set is of the data. So it's the most critical part to determine an algorithm's model's readiness, right? It's the locked-in model that allows, entirely new data from different hospitals, patient populations, and scanners. So you could have the best whiz-bang tool from your department or your institution, but if it can't be generalizable, it's not going to be very useful to anybody outside of your institution. The strong performance on an external test set is the best indicator that a model can generalize right beyond the institution where it was developed. And if there is no external test set or an algorithm has not gone through that rigor, it's a major red flag in both the AI literature and obviously for deployment when high performing lab models fail in the real world. And even taking a step beyond that, and it's something that is very difficult and where you need collaboration with institutions and with academic centers and with physicians that understand, is going through a prospective clinical trial. And this is where the AI tools integrated into the live clinical workflow. You look at the impact on clinical outcomes, efficiencies, decision making in real time, right? Clinical trials are rare because of the cost and complexity and the time that it takes to prove the clinical utility. But there's things like this bone age assessment tool or skeletal age assessment tool that did go through a prospective randomized controlled trial. But you can see it involved a lot of people, a lot of institutions, and takes time. And that's just one tool. And as many of you know, AI and the FDA have been approving, AI-enabled medical devices. But you can see here, radiology is one of the leaders for that, or at least radiology is one of the biggest areas of medicine that AI is being implemented in. And these are just an example of some of the FDA cleared AI co-pilots in clinical use, like acute stroke triage from Viz AI and AI Doc. So this is like from scan to, to table as far as trying to reduce the stroke or thrombus in the brain. Lung nodule detection is a very, again, low-hanging fruit. It's a very laborious task, and this helps, with lung cancer screening. Mammography risk assessment is also, we've heard of computer-assisted detection for a long time in CAD and breast imaging, but now you're seeing companies using and leveraging AI to not only diagnose, but also to predict tumor. So this is just to entice those of you that are interested in the AI space about why it's so important is because there's a huge, immense increase in volume in radiology imaging. Wages and radiology shortages are up both, and then residency programs are not able to train enough people to fill in those gaps. So this is where AI comes in, and we are looking for tools like AI to be our co-pilot, right, as an augmentation force. We're not looking at this as a replacement of the human aspect, but it's really to enhance and augment what the radiologists and clinicians do today. And you can see here, this is really what I'm focusing on, is it's improving efficiencies, enhancing diagnostic accuracy. And I think this is something that is going to be very, very exciting, is enabling perception beyond the human limits. So looking at data that we cannot perceive as humans, and maybe the AI systems and the machine learning can. I'm going to talk about some of those tools. So the efficiency piece, right? How do you automate tedious tasks? And one of the biggest tasks that we deal with day in and day out is this workflow prioritization. So imagine being scanning, from multiple sites and sending it to your radiologist. We have these work lists, right? You can see the color coding. Like today, we'd have like stat, urgent, and routine, for example. But imagine a world where the AI could potentially detect, right, detect disease and really promulgate that exam up to the top of the list, or move that triage so that we are reading the most important things in real time, and that the patients that are most critical or that need attention to the imaging is alerted or are alerted right away. So this whole idea of moving cases to the top of the queue is a huge area that's being worked on or has been worked on and will continue to be a major factor in how we look at AI improving our efficiencies in the reading rooms. The grunt work of image analysis. So take, for example, these segmentation tasks or tumor assessment task and tracking lesions over time. And you can see here, you get presented with a case that has, numerous and innumerable lesions. How do we track these? And how do we attest, for instance, if patients getting chemotherapy or radiation therapy? Or how can we tell that there's resolution or there is progression of disease? And this is where, and look at this like area of segmentation where we can actually get volumetric and instead of, these rudimentary, what's the length of a liver, but we can actually give actual volume. Or, we'll have new nomograms as far as volumetric nomograms instead of the length of the spleen. Or, for example, pancreatic or even vessel kind of volumetric segmentation. So my thought is that this is going to increase the need for humans to understand what is reportable, what are the nomograms, what is a normal volume of a liver for a 40-year-old, for example, or what if they have cirrhosis, or what if they have tumor. It's going to be very important to understand how to deal with this flood of AI-generated information. Hanging protocols is a huge factor as far as presentation of imaging to the physician or to the radiologist. Today, it's very clunky still. So, like for an example, if I want to look at current and prior exams, the exam has to match. We have to know like what the axial versus the coronal versus the sagittal view is. But imagine this multimodal type of hanging protocol where you're getting other information, including things from the electronic health record, where it's segmenting out and doing, the levels of the spine, where and what is being looked at, for instance, tumor or emphysema assessment. So all of these things are going to be very important to you to leverage AI to present imaging in a very productive way, in an efficient way, where I can make a judgment or interpret it in a much more cleaner and more useful way, both for the patient and for the referring clinician. This is an obvious one, right? This is where, we're thinking about having autonomous AI where it's diagnosing or at least putting a prelim report together. And there are examples of this that out there in the clinical space, or at least there are a lot of groups working on this. And you can see here that we have a left-sided pneumothorax, and you can see here that the AI is generating this report and impression. And you can see here that this is going to, again, add additional burden to radiologists. There are efficiencies, obviously, but is this correct? Are we validating this in real time over time? And I think we're going to see more and more of this sort of prelim generation. And it's going to be very interesting to see what people pass and what they don't pass. And I'll talk about some of the biases. And I think Dr. Shore is going to be talking about some of these biases later today. So the second pair of eyes, right? Enhancing diagnostic accuracy. This makes a lot of sense, right? There's a needle in the haystack. We're looking for subtle, tiny signals of disease with immense amount of noise, right? So trying to get the signal from the noise. This is going to act hopefully as a safety net, so reducing false negative interpretations. This is why, one of the reasons I work at an academic center is because I do have a second pair of eyes with trainees like residents and fellows that are the first pass in looking at an exam. So imagine having AI as that co-pilot in addition to the human co-pilot, how powerful that could be. Meta-analyses have shown that AI-assisted imaging can demonstrate significantly higher diagnostic accuracy. And again, this is very straightforward, or at least makes a lot of sense, and low-hanging fruit for the breast imaging world is having AI or CAD detect lesions, and then combining that with the human element. There are groups like in England that require double reading of mammography, double human reading by mammography, and they're looking at AI solutions to maybe alleviate that need for double reads. Beyond human perception, and I think this is one of the most exciting pieces of AI is really looking to perceive patterns that are invisible to the human eye. So things like radiomics and radiogenomics are extracting vast quantities of quantitative data from medical imaging and correlating them with underlying biology. So, for example, doing a pixel biopsy where the features of the tumor, such as the texture, the shape, the signal intensity, and heterogeneity, can create an imaging phenotype. And this phenotype can be linked to the tumor's genetic mutations, molecular pathways, and potentially clinical behavior. So, this is just an example of a pathway of looking at, let's say, an MRI scan and looking at the texture and contours of a lesion versus getting a biopsy, right? So in the biopsy case, you do have the tissue, you can run the genetic sequence and potentially providing a diagnosis. But imagine doing the same thing on doing a pixel biopsy, right? And really correlating that with the not only the radiomic analysis of what is in that feature of the tumor, but combining it with the radiogenomic or the genomics piece, and also coming up with that same determination. So you could potentially diagnose with confidence what a lesion or grade lesion or the diagnosis is to start therapy before even a biopsy or even alleviating the need for a biopsy. So this whole idea of prediction and forecasting, right? So the radiologist's task is no longer to detect and describe a lesion, but with your AI analytics, you can provide predictive insights, right? Inform personalized medicine, forecast treatment response, and predict disease progression, right? So you become the radiologist or the clinician. So you're empowering the radiologist to become a high value clinical data integrator and consultant. So we're not only integrating, but we're aggregating, we're integrating, we're predicting. This is just beyond description and giving differential diagnoses, but actually saying what we really think that this could be. But now we get into the biases, like for example, automation bias. So the tendency for humans to overtrust the output, right, of an automated system, especially if you have a lot of volume or in a high pressure environment. There are researchers that have demonstrated the impact of AI assistance is highly variable, where it can improve the performance of some radiologists while hindering the accuracy of others. And it's very important for radiologists to understand you can't blindly accept the AI suggestions. So the human must remain the final arbiter of the interpretation. So this automation bias was tested. For example, physicians received a chest X-ray with diagnostic advice, some of which was inaccurate. And this study was looking at whether or not the advice was accepted or not. As a group, the radiologists rated the advice as lower quality when it appeared to come from the AI system, and physicians with less task experience did not. So you can see here the AI affects different radiologists in different ways. This is sort of akin to people using GPS today. You're really the people that are completely reliant on GPS for their navigation will be is automation bias, where you don't know the street names, you don't know how to get to your destination without that electronic tool. So I think it's a very interesting point. Medical legal implications. So there was a mock malpractice scenario in 2024 where the radiologist who missed the finding was judged more harshly by a jury if the AI tool had correctly identified it. So this AI penalty highlights the urgent need to develop clear legal and ethical frameworks to govern accountability in this new paradigm. And so we always talk about how we, as physicians, have to follow the standard of care, and that the use of AI or at least the safest way to use medical AI from a liability perspective is as a confirmatory tool, right, to support existing decision-making processes rather than as a source of ways to improve care. In the future, AI will perform better than even the best physicians. We know that. And so how will we test that and how will we identify that? Because of the threat of liability, this will encourage physicians to meet and follow the standard of care and may reject recommendations and fail to realize the full potential of AI to the patient's detriment. So how do we bridge that chasm, right, from the validated model to the clinical integration? And this is where I will leverage my technical colleagues of how do we then implement this through, let's say, PACS or a radiology information system without causing instability or bottlenecks? How do we look at human factors, right? How will the tool affect radiologist workflow? Does it unnecessarily add clicks? Does it present information in an intuitive way? Does it save time or create new burdens? Looking at KPI, what are the KPIs? Is it reduced turnaround time? Is it the reduction of false positives and false negatives? Is it outcomes? Who's looking at whether or not AI is leading to better outcomes? So there's a lot of different key performance indices that need to be looked at with this. So it's not just about developing the algorithm. I think we sometimes stop and think, oh, we solved it, it's done. But there's a lot that goes around both the development of it, the integration of it, the implementation, and also monitoring. So fostering user adoption and feedback. So how do we build trust, right? How do we get feedback? You saw that, sort of automated generation of the chest X-ray report. How do we know that it's actually correct and we're getting feedback? Technical integration, so DICOM, HL7, RIS, EMR, how is this going to happen? Is it a native integration, with PACS, seamless experience, or are you going to bolt it on? It's going to be sort of a push or pull model with the PACS system and the server. So all of these are really important, especially me as an informaticist. If I'm going to bring an AI tool into my practice, I wanted to know that it works seamlessly and it works in the background and it's not obtrusive. This is just an example of a product from Gleamer looking at pediatric fractures. So you can see here it presents the native imaging and the AI-generated fracture detection. Legacy systems and vendor lock-in. So many systems you'll deal with older PACS or EMR systems that don't have APIs, making the integration very complex and costly. And then you have proprietary data formats where vendors create vendor lock-in, making it difficult to integrate best-in-class AI tools from third-party developers. So even when you do have a tool, you may not be able to integrate it because of your systems. The trust and the black box problem. So how do you get individuals like radiologists to trust an AI system that may have an output from, the imaging and may put a box around what they think is a fracture, but how do you build trust around what it is actually looking at? So, for example, saliency maps or heat maps, you can see here, this is that bone age or skeletal age paper showing where the AI was determining or how it was determining the skeletal age. So it's very helpful to prove to the end user of how the algorithm is working and what it's looking at. This fear of replacement and autonomy is always going to be there, right? So it's helpful and to frame this as an augmentative tool, right? Rather than replacing expert or handling repetitive tasks, like we really are trying to show that it's reducing or improving efficiencies and reducing burden. And this whole gain to pain ratio is you may have the best AI tool, but if it adds more clicks, or I have to like really look at it and proofread it or have to assess it, it may add more pain than the gain that I'm gaining from the AI system. So as I mentioned before, the AI must be embedded invisibly into the existing workflow to be successful. This is probably one of the most important slides of this talk is if you are going to work with a group or an organization, you want to make sure that they have some type of AI governance around the tool. I wouldn't just throw the tool at them and say, hey, we delivered it, but to really look at, do they have, the operations and the risk and impact, looking at the transparency and explainability of the tool, who's accountable and who has ownership over it and who's monitoring it, the development operations and compliance. So all of these things, I would ask questions to anybody, both from the vendor perspective and the clinician perspective, that this is in place before implementing or deploying a tool. And so with that, I hope that I covered some of these challenges and what role AI does play in the future radiology practice. I didn't go into the algorithm development, nor did I go into what tools are really being used out there fully, but I'm open for questions, and this is my email if you'd like to reach out to me. Thank you so much.
Thank you, Dr. Halaby. Both insightful and really sort of important topics from the clinician's perspective. I like the way you sort of approached what a physician may be thinking about, and also the sort of scientific grounding behind how useful some of these models can be and where they can be useful. I learned a thing or two. Also, my new term of art will be radiogenomics. I can't wait to use that in a sentence times this week or next. And I guess last point, my child who's learning how to drive right now, if I told him, you sometimes you can't rely on the GPS, you might need to learn how to read a map. I think I'd be in for an argument. So I wonder how exactly to navigate that one. Pardon the pun.
Yeah, that's a tough one. I think we all face that. And I think these challenges came in when calculators were introduced into math classes or PACS was introduced to imaging. There's these technical paradigm shifts have occurred and people have predicted the end of a field based off of those things. But we're going to have to find ways of adopting those. And Josh, I have some questions here from
Yeah. There's one,
Dr.
Dr. Primo's got one, I think that would be, or excuse me, Henri Primo has one related to actual use in daily practice.
Yeah, so I've used both the bone fracture tool, the bone age tool for my pediatric practices. I've seen people, or I actually use it for the intracranial hemorrhage piece, and also I've seen lung nodule detection used. I currently use in my practice. At least those are the ones that I'm aware of that my group uses. And then autoimmune diseases, I think I haven't seen specific ones for autoimmune diseases, but diseases in general that may come through an autoimmune way are they're not specifically target for that because there's so many different things that autoimmune diseases could um, present. Let's see. And I think I shared I'll put my email address in the chat if in case anybody wants to reach out to me directly.
Perfect. Dr. Hobby, thank you again. Again, it's invaluable to get the perspective of the sort of end user here who's got to navigate through all of the insights that AI can deliver, along with the sort of PACS and provider workflow associated with radiology. So really nicely demonstrating the why. And yesterday we spent a lot of time talking about the how these models are developed, some of the tools associated with these models, and then, challenges of managing the data. It's wonderful to see the sort of end result that you're describing here in terms of physician workflow. So thank you very much again.
Thank
Um,
you again.
you bet. So we're going to dive back into the how. So yesterday we spent a little bit of time talking about CNNs as sort of one topic that Roz covered. It's a really important topic though, because it's how much of this stuff gets created. And so we're going to spend a little bit more time understanding CNN architecture. Roz, the floor is yours, sir.
Yes, hi. So Raza Tanasiu, CTO at Baxera Health, presenting from Minneapolis, Minnesota, in the central US time zone. So this was very interesting. It's always great to see that all this abstract technology and math can actually be applied and how it's going to be applied and all the challenges of it. So great talk by Dr. Halabi. I would like again to thank everyone who at Paxera and our guest speakers for contributing to this set of webinars. Was a lot of work. So now we're going to go back to more math and more technology. So deep learning and specifically CNNs have become the cornerstone of modern medical image analysis. So they are designed to process visual data, learning complex patterns and features directly from images. So we will explore the mechanics of CNNs and how they extract meaningful information from medical scans and their role in accurate disease detection. And it is, essential to understand it at the high level. So some of the concepts are difficult unless you're, I mean, not difficult, but hard because you're not going to deal with math and this type of technology and software and on a regular basis unless you're a data scientist. But at the high level, you can understand how CNN works, and this is what we're trying to get from this segment. So the transition from traditional neural networks to CNNs marks a pivotal moment in artificial intelligence. To leverage local connectivity and spatial hierarchies, it makes CNNs highly efficient for image data. Those were the breakthroughs. They started with, for example, digits, just figuring out handwriting and the digits, and then it was the classic cats and dogs, and CNNs performed really well there. And then, of course, it evolved from there into true, applications for clinical use. So, breaking down the core components of CNNs. We have the convolutional layers, which are really the layers that are performing the feature extraction. Then there's the pooling, where you have that dimensionality reduction, and this is necessary. We'll have a couple of slides on that as well, just because you can't have exponential explosions of parameters and memory. Things can get lost, especially for models that are supposed to be more focused. Activation functions are extremely important because they have to introduce nonlinearity, right? It's all about overfitting, etc. And then, of course, you have fully connected layers for classification. How a complete training pipeline during the first session, we alluded to it. It's a very similar slide. So we have the forward pass, and then it's the combination of how we do the back propagation is what deep learning is all about, right? So you have the loss calculation, and you have the weight updates. So obviously, the training pipeline is not just the technical procedure, it is the foundation of clinical reliability. You can look at it that way. So by optimizing parameters and validating performance, we do ensure that AI models are robust and trustworthy. And understanding this process helps clinicians and developers, data scientists, collaborate effectively to build better diagnostic tools. Some interesting names here. There's a lot of math behind these optimizers. That's what they're called. SGD, Adam, RMS prop. Of course, we're not going to get into the details. And what I forgot to mention at the beginning of the session is you have these concepts, and if you want to dive deeper, it's much easier today. You just type it in, and you will get a good explanation from anything from, OpenAI and the GPT's Claude, or just a Google search typically will give you a nice AI synopsis. But it's also important to know how these things work together, again, at the high level. So forward pass, loss calculation. So there's a loss function in the mix, the weight update, and this gets back propagated to the gradients. And if you recall, we have many epochs and batches, and that's how the weights get constantly updated, and that's how the model learns the data in ways that sometimes can be mysterious, as we showed last time. But here's a more concrete example, right? So the CNN learns features at multiple levels of abstraction, right? So early layers detect simple textures, and then as with the middle layers identify, in this case, since we're talking about clinical, it identifies the anatomical structures. And then as you go deeper, you can get into more complex disease patterns. So the clinical insights here are profound. CNNs can be trained to focus on the most relevant features for diagnostic in improving accuracy and efficiency by leveraging hierarchical feature learning. And how these models can assist clinicians was illustrated by Dr. Halal earlier. So these convolutional layers use small filters to scan images and detect patterns. So filters are essential for feature mapping, and that's one of the major characteristics of convolutional networks. Um, the convolutional operation in the back is the backbone of image analysis. And you can, we have here an example like from the Keras framework. If you remember the frameworks, right? Keras is just one of them. Pretty much every framework can do convolution. And yes, the all those algorithms, the optimizers and the loss functions, etc., and activation functions, you don't have to implement from scratch. It's all done. It's open source. It's available. But you still need to know how to mix and match them. In practice, kernel and filter are used interchangeably as terms. Um, and I mean the small learned tensor that is convoluted over the input to detect features. Now, some mention that the actual kernel is the actual weight matrix, and the filter denotes the combination of kernel and the operation. Medical applications, of course, organ boundaries, tissue characteristics, disease signatures, etc. Filters, so you move across images to extract relevant features. So the key concepts here, think of it as you have a larger image, let's say 500 by 512 by 512, like a CT. And then you apply a kernel that is 3 by 3 or 5 by 5, right? And you move this along. And that's where some of so it's the filter size. Then you have a stride in terms of how many pixels the filter moves each step. You have padding. Padding is used, especially when you have smaller images, so that you don't lose the information at the edge. Especially, let's say you have a 5 by 5, right? I mean, if you have to cover all those pixels. And so basically what you do in order to get the edges, you add pixels at the edges. And then the receptive field of a unit in a convolutional network is the region of the input image that can influence that unit's activation. So and on the right-hand side, they have examples of filter types and medical applications. Again, all these are academic papers and you know, many implementations already exist as part of the frameworks we mentioned. And of course, we had earlier 3D examples, and Dr. Halabi mentioned how important volumetrics are, right? So not only can you do 2D convolutions, you have the ability to do 3D convolutions. Of course, the implementation is even more complex. However, these architectures are crucial for tasks like brain tumor segmentation, where spatial relationships across multiple slices are important. And that's in general for other examples as well. Organ volume measurements was also mentioned earlier. So processing volumetric data could represent computational challenges, but with advances in hardware and obviously software, it has made it feasible, right? So again, sometimes just because you can operate in n dimensions, yeah, and this is why you have tensors and that is why you have GPUs. You still need to make sure that you don't have an exponential explosion, in which case things will just not convert. Pooling. So this is all about dimensionality reduction and also translation invariance. So pooling layers reduce the dimensionality of the data. So they're making models more efficient and less prone to overfitting. That's really the main generic use. Now you have max pooling, average pooling, and global pooling. They're common techniques that help create translation, and it all depends which you're getting. But as you can see, you get from a larger feature map, you get to a smaller feature map, and then depending on which type of pooling you're using, you get different results. So pooling provides a translation invariance as well and builds hierarchical features um, out of small local patterns. Um, and it gives you a more abstract representation useful for higher level tasks. So it makes the networks less sensitive to small shifts or distortions in the input. Well, we mentioned activation functions as well. So here's another abstract thing. You don't need to remember these formulas, although they're not even that complicated, especially if we take the easy one, which is ReLO, so rectified linear unit. And the ideal there is that, it's zero for negative input and, you know, it's linear for positive ones. Um, and then there are different applications. So sigmoid application function, sorry, activation functions are useful for binary classification, and softmax algorithm is good for multi-class signification. So I'll just give you one sentence on softmax. So converts a vector into a categorical probability distribution, and those probabilities will add up to one. So then this is how you choose, for example, which, when you have a multi-class classifier, right, which the highest probability is probably your class that will be chosen. Leveraging pre-trained model, that's actually very standard practice this day. So you start the transfer learning involves starting with models trained on large data sets and fine-tuning them for specific medical tasks. So this approach will reduce the need for extensive medical data, making AI development more accessible and efficient. And by the way, you can train some, you don't have to necessarily start with a model that was trained on medical data. You can use a more generic model, and even that will help a lot. So you can typically replace the final classification layer, or you can fine tune it on a medical data set. But this is a very common technique. So at the bottom of the slide, you can see how this is done. For example, where you have the pre-trained model, you remove the top layers, but you keep the feature extractors, then you can add your classifiers. And then the fine tuning, you can fine tune all the layers on new data or just some of them. But what are the benefits? Well, they require less medical data, faster training times, and you typically get better performance, especially with small data sets. And small data sets are a reality these days. Here are some examples of these models. These are very complex models, pre-trained. They've been around for a while, and you always get either new versions of these models or similar versions, and they're typically open source. You can download them from, depending which framework you're using. There's repositories for these models. Um, Again, just something for you to be aware of, that these exist. And of course, some excel at better features than others, So that's this slide is it's giving you an idea on how things work. And then, of course, there's two major architectures here, encoder decoder, and encoder decoder is also part of transform, but the and the attention transformers and attention mechanism is also part of transformers. One of the go-to architectures for medical segmentation, for example, is the UNet architecture. So it is an encoder-decoder architecture with skip connections. And I will mention what a skip connection is, because that's very interesting. So skip connection passes activations from one layer directly to a later layer. So bypassing one of more intermediate layers. Why are we doing this? So between blocks with very deep networks, in order to prevent degradation. So this looks like I'm contradicting myself, because in a way what we were saying, well, we want to reduce the dimensionality, right? That's important because we don't want to have an explosion of parameters. But at the same time, sometimes it's basically you both reduce and add some of the earlier data again. And this actually gives you um, a very, very interesting results, positive results for sure. So medical applications, organ segmentation, tumor lesion detection, surgical planning, radiation therapy, right? And at the bottom of the slide, you can see the pipeline flow. So you get the input, the encoder does the feature extraction, the you get the context understanding, then you pass this data into the decoder, and then the output is a segmentation mask, which is a set of pixels. And then another common way to do this is to combine these, enabling image. So this is useful for counting tumors, tracking disease progression, planning surgeries even. So in medical imaging, instant segmentation helps clinicians quantify abnormalities, monitor changes over time, make informed decisions about treatment. Um, this can in addition to, so it's a single neural network and it predicts bounding boxes and class probabilities, but it can do this for multiple, multiple identifications at the same time, right? So it finds all the lesions, for example, in an image. And the good news is it's fast. So there is always a trade-off here between a balance between speed and accuracy. And of course, it has multiple versions, but YOLO is something that's used quite a bit also, and it allows clinicians to quickly identify these lesions and abnormalities. So because fast in this case, it's okay because you can even apply it to real-time monitoring. Busy slide, however, it pretty much, you know, gets you back to gives you an overview of here are some interesting architectures and what they would be best for with their medical examples as well. We mentioned ResNet, and YOLO, and we'll talk about vision transformers as well. The adversarial networks are used as well. And then, of course, autoencoders, that's kind of part of more than one of these architectures. So attention mechanisms. This is one of I think this might be my last slide. So I'll spend a little bit of time on it because we haven't talked much about transformers. Um, the emphasis is CNNs. And indeed, I want you to understand for the ones who are not, data scientists and experts, what the difference is what the difference is, right? So CNNs are more, in a way, more focused on medical. They're not necessarily general purpose algorithms, right? So you have a problem, you identify your problem, you train it, and usually supervised training, and that's how things work. So, we think that CNNs are still here to stay because they're perfect for medical imaging and vision in general. But as you know, the world was taken by storm by generative AI, right? And at the core of generative AI is the transformer architecture. The paper about multi-head attention from researchers for Google, so it started in 2017. Another nice and popular architecture was BERT, B-E-R-T. And initially, this was done it was perfect for translation, and it worked the same on encoder, decoder. You would encode in one language and decode in the other language. But then all of a sudden, things got very interesting. So vision transformers and attention mechanism represent the next frontier in medical imaging AI. So these models actually capture global context and deliver state-of-the-art performance in tasks like multi-organ segmentation and 3D analysis, right? So transformers are now used as well, and they have some advantages. I'll just mention quickly what the attention mechanism is. Okay, no, it's abstract, of course. It computes weighted interactions between a set of input tokens. So each token aggregates information from every other token. So an example would be we talk about language, right? It's rather than have a sparse matrix with each word, etc. If you give it a sentence and each word is aware of the other words in the sentence, now you have context. Okay, so that's kind of the idea between attention, and then with multi-head attention, which is at the core of the transformer architecture, you have several attention heads in parallel with different learned projections, and they concatenate their input and apply a final linear projection to let the model represent multiple types of relationships simultaneously. And this is how the magic happened. So vision transformers are a little bit more involved here because what they do, they convert an image into a sequence of flat patch tokens by splitting the image into fixed size, non-overlapping patches. And I will stop here because think of it as the patches now being the word example from the beginning. So now you have these vision patches, right? And segments of the image, and you get the same multi-attention correlations that you would get with words in a sentence or a paragraph. Um, and what, treating patches as tokens, tokens, that's another word that all of you who have used ChatGPT and paid for it, it gives transformers now global receptive field from the first layer, enabling long range context modeling across image regions. And what's important, well, we're not doing this for the sake of math. It's in our case, there are medical applications here. So we have the 3D medical image analysis, whole slide image analysis, etc. So here's another example, and Dr. Halabi also alluded to it, is um, you can go from a vision transformer to text, right? Because that's the multimodal thing, right? And many of you have experienced this by, okay, here's a description of a video or an image, and the image gets generated, or the same thing around, or the other thing around where you have the image and you say, okay, describe what you're seeing. Well, from a medical perspective, you could generate even a report from a medical imaging. Now, again, and there are specialized models that do this. So it is a very interesting technology. Clearly has phenomenal applications everywhere in every single domain. But we don't want to dismiss the CNNs either. So there's a trade-off, right? You can go more generalized, or you can go more specialized with the CNNs. Um, the same good, the same best practices apply here also. So. And with this, I thank you very much.
Thanks, Raz. Raz, there are a couple of questions in the Q&A that I want you to take a look at in particular, and perhaps you can answer via text response. Um,
Yes, I'll take a look, and if I can answer either way, I will answer, but via chat. Thank you.
Wonderful. Thanks, Raz. And look, I think it's really, I really like the way you ended, a scenario and the techniques and technology related to how a model was created, like what Dr. Halaby was describing earlier, where you have an image and you have to get a report out. So leveraging all of those techniques that you were just describing, Raz, to get to that endpoint, I think we all would agree, just based on all of the different techniques that have been discussed, is clearly not simple. It's
Yes,
not, we haven't simplified this process. In fact, we've added complexity to be able to get models to work in the way that radiology is done today. I think what's heartening is it's already happening. It's in the field. We have examples of AI, both on the diagnostic and on the workflow side, that are actively sort of being used. So all of the background that you were just describing, has been put to good use. And I think, Dr. Holloway mentioned, almost all of the AI in healthcare happens to be focused on radiology. I think that has a lot to do with the sort of diagnostic mission of radiology and also the fact that all the data is pixelated. Most of the data is pixelated. So it lends itself to that sort of capability set. I guess where I'm heading is um, it's really useful and good to hear that this framing that you've just provided is being used to develop AI today that's used in the field today.
Yeah, and you can use it for everything. I mean, obviously, we emphasize because that's our specialization and that's the interest of our viewers. Obviously, was about medical imaging, right? And then CNN's vision transformers, they're perfect for this. But AI is a great technology, and while sometimes, definitely my slides are the dry ones, there's two purposes. First is you can look up the concepts, just high level concepts, and then you have an understanding. And second, it's not magic, it's really math. And some of it is becoming a commodity. Yes, so all these difficult implementations that are implementations of research papers of people who have done research for years in this domain, but at the same time they're open source implementations right now available. You still need to know how to combine them, but this is, in a way, we're trying to demystifying all this thing because we are in a hype cycle in a way. But the exciting things are the things that you saw from both Dr. Ilyas yesterday and definitely Dr. Halabi, where actually it can make a difference. And he said something that I also said yesterday. We don't want, even if the model is great, we don't want the clinician to be, double checking it and lose more time, even if it works well, right? It needs to be an accelerant and a
Indeed.
productivity tool. So thank you all.
Indeed. Well, thank you, Roz. We really appreciate it. And yeah, please take a look at the chat to try to get some answers to several folks who had specific technology questions. Okay, so we are at the end of the session. We are rounding the corner into the straightaway, and I'm really excited to hand the mic over to Dr. Mohammed Shora, the CEO at Pexera Health. He's going to dive into advanced learning paradigms, leveraging some of the technology that Roz was just discussing. And then also, he's going to talk really as a follow-up to what Dr. Halaby was talking about related to sort of the right sort of appropriate use. Dr. Shora is going to dive into ethics, bias, and integration to get more into that conversation. So with that, Dr. Shora, you have the mic.
Thank you, Josh. Thanks everyone for attending the course. Hopefully it's beneficial for everyone. So I'll share my screen. Great. So my name is Dr. Mohammed Shura. I'm the CEO of Pexera Health and teaching faculty in the Johns Hopkins School of Medicine in Baltimore. And today again, we're gonna continue part two in the AI course, which is hopefully again it's gonna continue, in other times, in other topics, maybe in other languages. And again, this is under the a great help from Paxera Academy, which is aiming for teaching again more people again about the AI in imaging, which is some of us again are lagging behind, and this industry is moving so fast. I just came yesterday from Irvine, California, attending the Kimimi conference, which is under the SIM, Society of Imaging Informatics, and the industry is moving very fast, and we need to catch up. So I'm gonna talk today about few topics, the labeling, federated learning. I'm gonna talk about the types of algorithm, giving you an idea about the status quo now in the industry, and then talking about the what is the commercial algorithms, what is like the PACS vendors again doing with the AI algorithms, and the marketplaces. And we're going to talk about also self-development of algorithm, which is maybe some of you might be interested. Federated learning is actually how to do a multiple collaborative AI algorithm development across multiple maybe institutions, maybe country. And this is mainly the purpose for that is for privacy, preserving privacy. So that actually will be like a local training. Let's say there is like five, six hostels, different entities, different institutions. They are trying again to do some algorithms together, but they don't want to share data because the data is again, like private for them. So they can do a local training, on the hospital in each hostel server, and then there'll be a model aggregation. So like one model again will be, let's say, in a common server shared by them, but the data will not be moving. The actual imaging data will not be moving again to the main server. The images and the data, the medical data will stay as is, but only we can exchange the models or what's called hyperparameters. And that model of federated learning have gained a lot of potential for the last few years because of the common research, even research again via different hospitals, different institutions, that like, get a lot of trust. And again, this is for privacy benefits, this is for clinical advantages. So again, every hospital can freely be able to conduct this kind of research. Here's again a few graphs again show how it works. So again, there'll be like maybe say one server, and let's say there's like three institutions. Everyone again will be doing the training internally. They will have data, and then once they finish the training, they will send the weighted files or the hyperparameters or the models again to the main server, and the main server again will have will create the model or create the algorithm without the need to move the data to the main hospital. So every hospital or an institution will preserve the privacy. There is also another topic is ensuring clinical reliability. So because of like without the right data, without the right label and labeling of the data, we will get it's garbage in, garbage out. And so the internal validation is really important. So again, we have to make sure that like in every organization, and again, I'm assuming now that the market is between, let's say, you can go and and we're gonna talk about that in the next few slides. You're gonna go and you decide in your organization that you're gonna buy an algorithm, right? And you can also decide that, what, I'm gonna build an algorithm. Or you can take a pre-trained model, an existing algorithm that is like available, publicly available, that you can need to retrain it on your data and use it. So we need to make sure that we have an internal validation. We test the data. We monitor the accuracy, the area under curve, the AUC, sensitivity, specificity. We do also external validation. So we test on the data from different institutions. It's not only that the algorithm again will be working well, efficiently on your data, but sometimes again you can get different race, different, let's say, demographic group or age group, or a different, again, clinical, settings that is different than the data, again, was trained on that algorithm that you're using. So you need to do an external validation as well. Clinical validation, you need to test that in real clinical settings, meaning that, again, you test, the algorithm in the lab, you test it internally, you test it externally, but you need to go ahead and like go into a clinical validation to make sure that the system's working on a real patients, and that again will require a clinical validation on an actual PACS viewer, whether this is a research PACS or this again will be like the actual clinical PACS that use it every day. There is also again very important aspect is again always again when you do the validation, and this is an example of validation. That project again was done in University of Florida. To they were trying again to build an algorithm. They were working with us again to build an algorithm to detect the mandible. And again, here is the result. So they were trying again to make sure that the ground truth, their segmentation of the mandible in a dental X-ray, it matches or it's very close again to the predicted one to compare it. And again, actually, if there is like this is 100% matching, which is never going to happen, then it means that the algorithm is working very well. And we need to make sure that we're testing, and this is like for the internal and external testing. So again, maybe for the first, again, we have the green and the blue, and the blue, for example, again, are again showing the predicted one using AI, and the ground truth is um, my own labeling. So now again, the predict the probability of that is like 94%, and that means that 94% uh, the prediction is similar to the ground truth. And for example, if this is 96.2, so it means that 96.2, there is like the prediction and the ground truth are the same. Here, for example, showing that we use a model called VGG, which is a famous one, and we use 30 epochs in doing the training. Here also, again, it's like very important again to see, the different graphs and, different experiments. So every time, again, I'm training a model, it's called an experiment. And, I have, let's say, 5, 6 experiment I'm running to make sure, like, how the model is performing. So for example, in experiment one, we have seen 100 epochs. And then by reaching the 100 epochs, we're reaching like a very, let's say, very high accuracy. Now, again, we're still testing, so it's now almost 40%. So that as algorithm is not functioning well. Maybe I need more epochs. I need like to change the data. I need again to do again, apply maybe a different model. And then also like I will see the validation. So the training and validation, is not like, again, fitting together, which is also another problem. We talked about it yesterday, for overfitting and underfitting and the best fit. Uh, Also, again, ensuring an equitable healthcare IT, so the bias and fairness in the AI. So we need to again to track, the data bias. So data bias is, really important. So we want to make sure that, that there is no bias in the data, meaning that if I apply, again, if I train the data and then mostly again I will apply, let's say, an adult data, and then I try to pediatric, there will be a bias to the adult. Or let's say there is uh, I train my data on African American, let's say, or Asian data set, then there will be a bias again for the Asian data set. And that means that like, I have a problem. Because again, if I test another type of uh, unrepresented populations, for example, then I not have a problem. And I remember, one of the things that, my mom got hepatitis C. And again, when again you're asking in the US, like, what happened, hepatitis C, they will say she was drinking. And, again, as a, maybe a culture thing in the Middle East, again, the drinking is not happening a lot, the alcohol. So that was maybe for the hepatitis C that leads again uh, to the liver cirrhosis. Why the liver is cirrhosed, they will mentioning that this is coming from the alcohol, and again that is not happening maybe in this part of the region. So that can be a bias even in the socioeconomics in general, demographics in the data. Um Age group also is different. Like, are we treating, a patient that like having, maybe, 70 years old, or like this is like a young patient. So again, this is all parameters that we should take into consideration. Labels are again the most important thing, because again, if you have uh, your annotation or your labels, the ground truth are not accurate, inconsistent, that's also another problem. Always again, we should do like a review on the label, and that will be like a peer review, that has to be done to make sure that, that is, done correctly. One of the problems that happen in the public available data set existing over the internet, that some large organizations have shared it. Some of them are not really labeled in the right way, and some of them are not labeled by radiologists. So if somebody is used it without an extra validation, then it will cause like a bad performance of the of the models. Uh, Deployment bias as well. Again, unequal access to AI tools. So again, do we have an access to an AI tools that really can be able to validate, my data? Do I have, the right dashboards and the right graphs again to tell me exactly is the model performing well or not? And again, the solution, the mitigation for that is always diverse training data set, performance evaluation, bias detection algorithm. Sometimes the AI can again, detect that. One of the attendees again was talking about the GAN, general adversary network, which is maybe some of the which is actually a protocol to be able to test to generate like a fake data, not actually a fake data, but a test data that the AI can invent a medical images that have a specific problem, and that can be like very like a it can be an issue if the algorithms to predict or generate the GAN is not right, or like a really like fake images that is not like clinically right, that can produce a problem. So again, this is all again few things that we need again to consider again when we are doing the algorithm or like testing an algorithm or developing an algorithm. Here's also an example again, like we're labeling data, and again we can have like multiple across a volume, let's say in a liver or a kidney, and then again we need to make sure that there is multiple users, can validate that. So like in some sort of a peer review to make sure that the two user testing that or doing the label, are again they are equal, and then if there's like something that they are disagreeing on the results, then it has to go to a committee member, like, maybe the head of department or somebody more senior so he can judge and again, checking if that is the right level or not. Again, responsible AI development and deployment. So, we want to make sure that the transparency is very important. So, clean documentation of the model, capabilities and limitation. It's very important to know. I mean, one of the very famous example in the chest X-ray, for example, that some of the chest X-ray algorithm are facing a lot of problems because they were originally not trained on an emergency data. So emergency department means there is like wires on the patient chest, catheter, there is a EKG cable, and this is totally different. A patient again in the ER or the ICU, and then we have like a patient doing a chest, just like a normal chest X-ray. That is totally different. You can't again train like or provide an algorithm that was trained on a normal chest X-ray screening, and then you apply it on test data that is like full of like other uh, uh, things and objects that can confuse the algorithm. So it's very important to know that what is the like how this model again was like tested, used, and like what is the right application for that. Accountability also, we need to make sure that we are there's a clear responsibility for AI decision. So again, there is a lot of regulation around that, especially in Europe and the US, because again, there is always hallucination. There is like, and always, we can get a report or a decision that can affect the patient life, and that has to be validated again by a human. We have seen again still again till now there is like airplanes that like is being driven by a captain, although it's an autopilot, but there is always, captain, a pilot and co-pilot. And, they cannot just like leave and, the plane and sleep because again, it's like run by an AI, run by the autopilot. Fairness also, again, testing across diverse patients. We talked about that populations. So we cannot just like test the data on Asian or females and males or like, again, a specific age group. We have to make sure that we tested, across different patient population. Privacy. So again, data again has to be anonymized. Anonymization doesn't mean like remove the patient name. We want to make sure to remove all the PHI, all the protected healthcare information, from the patient, making sure that like we're even if there is a 3D reconstruction and the face again would identify the who is doing the exam, then we have to change that and, make sure that we have a little bit of a dithering to the image to prevent, identifying the patient. So again, HIPAA and GDPR is very important to consider. Bridging AI development. So again, in order again to, let's say, we develop an algorithm, or again, we take an algorithm available in the market, and we want to apply it to make sure that we have a clear uh, PACS integration. Unfortunately, the PACS integration, is not like really satisfactory to most of the people. Again, it like, mostly it's like a snippet that will, like have a flashing thing. Again, if let's say the AI have discovered something in the image, still that is not enough. So we need again an interaction and maybe like a chatbot inside the app, that will show a few things, whether a heat map or a segmentation or a label on the image, that telling me what's going on. The integration um, standard for that is called AIR, AI results, which is an IHE integration profile. But again, we're still, unfortunately, still very far again from having the right PACS integration. Again, talking about the real-time interface, so making sure that they are running on the hospital server or cloud infrastructure, are connected to the system. Definitely, again, we might need access to the patient chart. Again, we're not again we're talking about imaging here, but also the EHR information is very important. Again, to make sure that how if we are going to write a report, you can't just write a report by just reading the pixels. Again, we need again to see the patient chart and what's affecting, what happened in his case. Because again, a patient having hepatitis C and liver cirrhosis, most probably he's going to develop an HCC liver cancer. So we need to know this kind of information, what medication he's taking. That is all again should be also there. Workflow integration to make sure that how the AI results can be somehow contributing to the patient report, to the patient report that being generated by the radiologist, and how this is going to be approved. Continuous learning also, models cannot be version one and having as a black box, and then by the time again we leave it as is, because the nature of AI algorithm, they drift over time. That's a fact. All the research have proven that. Is again the future again is gonna show something else. Again, we're still seeing now everybody again, especially in the community conference that was there this week in California. They were talking about the big hope of the foundational model and LLM. Is it really gonna change the imaging AI forever? Again, we're still in trying to see what's gonna happen. Um, so again, I'll skip this slide, but I will go to also how the AI can be a clinical partner. So augmentation, of the AI algorithm. So again, the AI will enhance radiology capabilities, providing decision support, while maintaining a human oversight and clinical judgment. Trust through transparency. So we need to again to build confidence and enable clinical validation through get heat maps, decision pathways, labels again that will show what's going on, or maybe a chatbot, with, again, ability to do prompts again to understand, what's next. There is also the multimodal fracture. So again, everybody's talking about, the multimodal, meaning that I'm not only getting images, but getting text, EMR data, genomic data, clinical data that can help us into getting to the next level. I want to move to this again, showing you what's going on in the industry right now. So we have three buckets of things, and there is other bucket again I will dive in, but we have the diagnostic viewers or the PACS vendors. The PACS vendors existing, and GE, Philips, Siemens, Agfa, and Telluride. Paxera is one of them. Is it really a static PACS viewer that just again view, and then there is maybe integration with AI. Unfortunately, we haven't seen a PACS vendors have really created algorithm and have it built in, because maybe they feel that this is a very long process. It takes a lot of time. It is difficult. And then again, we have seen a commercial algorithm. Again, we have seen very famous names, Gleamer, Viz AI, Doc, Lunit. Everybody is focusing on a few algorithm. Gleamer, for example, is focusing on bone fracture, Viz AI and AI Doc, they are focusing about, the ICH, brain hemorrhage, other applications. Lunit maybe is focusing on mammo. Harrison is focusing on X-ray and so forth. Paxera actually is also going into, having commercial or like, helping in self-developing algorithm. But there is actually new industry started like a few years ago, and we don't know the future of those marketplaces. There is like a big shock in the industry happen by Blackford, which is acquired by Bayer or Bayer. They where those marketplaces are integrating the commercial algorithm into the PAX vendors and trying to integrate those applications. Again, is that the future? Blackford have divested the business, Bayer have divested the business and fired everyone, and Blackford is not anymore in the market, and they're gonna shut down their platform. There is Carpel, Black Sea, some others. Uh, again, can we see in the future, like really the PACS vendors will develop their own algorithm? Do we see the commercial algorithm are really, again, having a tight integration to the PACS, vendors, again, without having the marketplace? Again, that we'll see, in the future. There's also a fact, that, let's say again, we have seen like few, commercial algorithm again existing in the market, and, we have seen, some applications, but like how many applications have been developed? Again, we see that there is no more than 25, maybe 50 clinical applications that have been existing in the market. Mostly maybe 80% of the commercial algorithm in the market are focusing on the chest X-ray, brain hemorrhage, mammography, microcalcification and density, and other like bone fracture, maybe in, other, applications. But what about the rest? We still have a lot of application, a lot of findings, a lot of abnormalities that we need to tackle. How are we going to tackle that? We're talking about at least 10,000 algorithms needs to be created. How are we going to create that? Nobody knows, right? So, there is like we have, let's say 50, let's say we have 100 on commercially available. Uh, you know, the problem also, they are expensive. It takes again time to integrate them. They are not available to everyone. Some of them, are only on the cloud. Again, maybe some of the organization, let's say government, cannot trust them again to have their data on the cloud. So how are we gonna go from the 25 to the or 50 or 100 to the 10,000? If we have the same pace, that will take 350 years to reach that goal. And during the conference last week in the Simimi, they were talking about the rise of the self-development algorithm. So do you have really the tools to develop algorithm yourself, or taking like a ready-made algorithm and tweak it on your data? That's like the make or buy decision in every organization and every business, talking about, shall I make this or shall I buy this? In order to make it, do you have the right AI, the right talents and resources to build an AI? Do you have time to do that? Do you have like software development tools? If you buy it, can you afford buying it? There is only few algorithms existing in the market. There is like a privacy risk. And again, those are the steps again, trying to, again, how to you can build, your own algorithm. So again, this is like a, an open-ended discussion. Are we gonna, as an organization, are we gonna make it or buy it? Are we gonna see, a lot of like self-made algorithm? And actually in the United States and most like the elite institution in Europe, every single organization, especially the academic ones, are building their own algorithms. So you see Mayo Clinic, Mass General, University of Florida, NIH, all those guys are building their own algorithm, and they are trying, and they have labs, AI labs. And again, this is like an invitation for everyone. Consider this, like again, see how you can, maybe you can, work in a group again to either test like commercial algorithm or developing your own algorithm. So with that, again, I think we have concluded our session, and let's see some questions.
So, Dr. Shora, the questions are going to show up in the Q&A box. So please select the Q&A box. There are a couple for you that I would like you to sort of consider as you read through them. If it makes sense to share the question out loud, go for it. Or if you think responding via text makes sense, I guess do that instead. Um, there are a couple of questions here around sort of guidelines on when to use what. Like which multimodal tools to use, what techniques make the most sense, GANs versus CNN versus others. I think, I want to make a blanket statement, which is that, our industry in radiology, we are reacting to what I would describe as the more vanilla sort of generic AI tools that are available. They get made, LLM's a great example. OpenAI has an amazing innovation they bring to market. And then not just radiology, but almost any sort of subsegment in every industry kind of has to react to that new amazing capability. So, before we answer what some of these recommendations might be, this space is moving incredibly fast. You know, we didn't have LLMs until 3 years ago. Tomorrow, what's going to move this industry will not be an LLM. It will be something more advanced. But anyway, I'd love for you to take a look at some of those questions and maybe respond as you see fit, Dr. Shah.
I replied to all of them. So the one that you were commenting on is a duplicate. So there's like
Okay.
23 answered questions.
But it gave me
There's
such a
one that I
great,
don't know how to.
sorry, go ahead, Rose.
Yeah, anyway.
It gave me such a great way to close it up. So I had to describe it.
Right, but all I'm trying to say is there are some answers we didn't stay still, right? So anyway,
Yeah.
thanks.
I think I can
Close.
answer one question. So there's one question again talking about do you again recommend ChatGPT 5 again for medical use? So again, that is still ChatGPT, OpenAI, Gemini, DeepSeek, all those are again LLMs. There's like actually an LLMs and VLLMs. VLMs is the vision model. And for example, Gemini have produced MedGemma, which is the vision model, and it means that it deal with images or again multimodal data. So using you can just like just like put a CT brain image and like put it in ChatGPT and hey, write a report for you. It doesn't work this way. It can give you an answer, but the probability of like having the wrong answer or has hallucination is like very high. Uh, uh, again, are we gonna see an improvement? Yes, but again, we cannot just like have a commercial algorithm was like designed again to deal with text and even deal with images, but again, not a medical images. So MedGemma, for example, was utilized. Can we use just like MedGemma if we got access to? We definitely will need like what's called fine tuning and for the models to be able to do that. And actually, we provide literally in our platform like you can take like an LLM and start fine tuning it on your data so it can give you the right response. And by also giving some prompts again in your that like you need to follow or the algorithm need to follow to make sure it gives you the right answer or to exclude this. So for example, like exclude patient data because it might be like sharing a PHI on your data. So this is like how it goes. There is also other question, should be a patient specific or a disease specific. It is the personalized medicine is like, is patient specific, right? But again, is the personalized medicine like, do we have a lot of application in AI? Still not, but it's always, I will call it abnormality or a finding specific. That's like the most of the applications. Can we see a patient specific? I don't think so because like, yes, God forbid, we can all get like a lesion or a mass in the brain and it doesn't mean that like me or anyone again will get like it has to be equal but again it can be different like my body is different than like the other body but again this is like the work of the AI that he can identify the different kind of images like and how an image will be different from another image.
So for the other questions, I know we're reaching our time here. For the other questions, I think we will respond like we committed yesterday. We will respond in digest form electronically and make sure when we share the recording, we can also share responses. Um, I want to thank the attendees who were with us yesterday and today. Really a ton of content and should provide you with a basis or a foundation for additional exploration and potentially even use of radiology, artificial intelligence. And then, of course, I want to thank our presenters. Great work from our industry guests, Dr. Elias and Professor Elias, excuse me, and Dr. Halabi today, and of course Dr. Shora and Raz today. Well done. With that, I think we'll be concluding the session. Please note recording and again response will be disseminated via email, however you registered as a follow-up. So thank you everyone, and have a great end to this week.